Okay, I don't think there's going to be much debate. I think we're going to probably agree. So this is not what we're talking about. This is somebody I took care of in Iraq in 1991, but we're talking about diabetes. And the question is, how are we doing with amputations? And if you look at Medicare data recently published in 2013, it looks like there have been less lower extremity amputations that have occurred over the past decade. And really that's come at the expense of a reduction in major amputations here in the United States, but minor amputations are increasing. And I think largely that's due to the success of, Dr. Conti and Dr. Pomposelli, that because vascular surgery has really taken so many huge leaps forwards, that they're doing a better job and we're preserving limbs and ending up with more minor amputations, which is a good thing. Now, what about these rise? Well, if you look at midfoot amputations, they've actually declined by 24%, and metatarsal amputations declined by 12%, and really the rise is due to toe amputations. So I think all of us would agree that that's a success. If people with diabetes can walk around with absent toes, that's not a big problem. So I think our vascular colleagues are doing a great job in preserving limbs. Now, the question is, what do patients fear the most? And I got interested in this about 2 months ago. And in the last 2 months, I've had 138 of my patients come in, and I've asked every one of them the same 5 questions. And I had 30 patients that came to me for reconstructive problems, not diabetic foot problems. They didn't have ulcers. They didn't have Charcot. They didn't have infections. Then 108 patients who had a diabetic foot problem. And I asked them to rate their biggest fear. And I came up with these things but just by asking them spontaneously, what's your biggest fear? And I came up with 5 things, and 1 would be a major amputation, 2 would be going blind, 3 would be a death from a stroke or a heart attack, 4 would be an infection in their foot, or 5 going on dialysis. You'd be surprised at the number of people with diabetes that say, you mean I can actually end up on dialysis because of my kidneys? So what I found was that the greatest fear overall in looking at these 130-some patients was blindness and amputation were very close, followed by dialysis, death, and then finally infection. Now the interesting thing, if you broke it down by the 2 groups and you looked at patients who had a diabetic foot problem, amputation was their biggest fear. If you didn't have a diabetic foot problem, it was actually blindness. And it's an interesting thing. I would ask you, you should do this with your patients. It becomes a very interesting thing. They actually want to know what you fear the most too. And actually it's also very interesting that their spouses want to interject when you ask them these questions. And every one of the spouses, the big problem is they fear death. But patients with diabetes and a foot problem, you can see death is actually 4th, but amputation is something they fear. And I liken that to, if you ask a patient with cancer, do you fear dying of cancer? The answer is yes. But if you ask a patient who doesn't have cancer, do they fear of dying from cancer? The answer is probably no. And so the bottom line is when you compared these major fears, there was a significant difference in how they perceive the amputations. Patients with diabetic foot problems, such as a Charcot infection or an ulcer, fear amputation to a greater degree than patients who do not have a diabetic foot problem that have diabetes. All the other things did not reach statistical significance. And I have 130-some patients, and I'm probably going to continue this up into the 500s and try and just see if we can come up with anything. But the bottom line is, I think the patient's fear is based on what they have. If you're treating a patient with a limb-threatening problem, such as a foot ulcer, Charcot, an infection, they're going to fear losing their limb. Blindness, death, infection, and dialysis are equally feared between the 2 groups. So if you look at transtibial amputations in patients with diabetes, we know that major amputations are associated with premature morbidity, premature mortality, associated with contralateral foot problems, and reduced ambulation. And if you look at the study from Georgetown, they found that 52% of the patients died, in 2 years, and that's Chris Addinger's center. It's a great center. And of the survivors, only 2/3 were able to ambulate with a prosthesis, and these are below-knee amputations. If you look at the quality of life of a patient with an amputation versus a diabetic foot ulcer, it's very interesting. If you look at the SF-36, which is a very common generic form of quality of life, looking at 8 different subgroups, and what they found actually that patients with a transtibial amputation actually had less body pain than people with active ulcers. So this was a study that showed there was no difference in how patients with a below-knee amputation perceived their quality of life compared to patients with an active foot ulcer. And so is amputation really the culprit? And I think not. I think if you look at the literature and you look at this cancers we've seen, but if you look at a healed ulcer, you look at a Charcot amputation, the 5-year survival is not great for any of these patients. So it's really not the amputation that's the culprit, but amputation is a surrogate marker for underlying disease. And if you look at our vascular amputees, they tend to walk slower than control patients after surgery. As you can see, the more proximal you go from a foot amputation to a below-knee amputation to above-knee amputation, they walk slower. Why do they do that? Probably energy expenditure. They may not have the cardiac reserve to walk at a normal speed, so how do they do it? They take fewer steps. And again, the energy expenditure, the more proximal you go, the more energy expenditure that you're going to require. It's interesting, if you look at that, some people are very much advocates of SIME amputation at the ankle, but a SIME amputation really is not an energy-preserving amputation compared to a below-knee amputation. And again, proximal amputees take fewer steps per minute. So not only do they walk slower, but they take fewer steps because, again, probably the underlying disease. So the bottom line is, when you have a patient with a below-knee amputation, they adjust their gait velocity to reduce their energy expenditure to a level similar to the control groups. And traumatic amputees will walk faster than vascular amputees because they're younger and they probably don't have significant coronary disease. And so I looked at a group of my patients that we did below the amputations, and we looked at a region-specific assessment, self-reported, and the SF-36 was a generic assessment. And what we found at 1 year in 21 patients, small study, that their physical component summary score and their medical component summary score actually went up. And these were non-reconstructible Charcot patients who had infection. And so when you have to call it quits and do an amputation, I think we can now tell them that there's a select group of patients that are actually going to do very well with a well-done below-knee amputation. That probably represents about 5% of the patients that I deal with. And I was trained in the military 30 years ago, and as a young military surgeon, I dealt with a lot of young amputees, kids from explosions, mine injuries, etc. And we never approached amputation as a negative thing. It was always felt to be the first step in the recovery. And I do that same thing with my patients with diabetes. And so I think in selected patients, you can improve function. We published on our first 13 in diabetic medicine, and 12 out of the 13 patients actually had no regrets and told us that they would do it again. The only unfavorable outcome that I had in my first 13 was somebody that I probably shouldn't have done a below-knee amputation on. They had a BMI of 60, they could not wear a prosthesis, and they would have been much better off with a knee disc articulation. Going forward in my 21 patients, 20 of the 21 now said that they would do it again. And it's interesting, on these patients with these chronic infections where you spend a year reconstructing them, invariably they come back at 6 months and tell me, if I would have known how well I was going to feel, I would have done this sooner. So there's a certain time in your treatment where it's a good idea to call it quit. But the nice thing, if you're not doing it for a limb-threatening infection, you have time. The patient can make that decision. And I think all of these patients have played a major role in their decision-making. And when they make the decision to amputate, they generally do well. It's a drastic step in patients with diabetes. Patients fear amputation more than anything except blindness, like I said, especially when they have a diabetic foot problem. The goal should be the most distal amputation that gives you a good reconstruction. And I think a well-done below-knee amputation is a good operation that all surgeons who reconstruct patients should be able to do. That's it.
Well, that was not too bad. And everyone told me, be careful, he's going to tear you apart. But I actually don't disagree with anything that my colleague said, and I actually agree with his conclusions. I think in appropriate patients, an amputation is the right operation. Everybody knows Oscar Pistorius. I guess he went from famous to infamous, and certainly currently on trial for murder, the tragic circumstances and death of his girlfriend. But I think we would all agree that his performance in the London Games was an inspiration to amputees around the world, and I think that was certainly a good thing. But as Dr. Wukich said, these people are not the patients that we treat, at least I don't treat in my practice. and they're not the type of people that we're talking about. And I'll concede right up front that for a younger person with a traumatic amputation, for tumor, or even a Charcot foot deformity with good circulation, it may be that these people are highly functional to start with, and amputation is the best primary treatment. And then, of course, there are those patients where there's absolutely no other alternative, the unsalvageable limb, which fortunately we're not seeing as much nowadays as we used to. These two, amputation is not only the best strategy, it's a life-saving treatment, and it's the only treatment. But the people that I want to talk about are the dysvascular, older diabetic patients. And I think it's, patient selection is everything, and I'd like to look at amputation in these patients because certainly this is the bulk of my practice, and I suspect a large portion of yours as well. And as was already alluded to, the amputation rate in the United States, New York State, and this commonly referred to study looking at the NIS database by the Columbia Presbyterian Group showed that there has been a stepwise drop over time in the number of major limb amputations. And of course, you notice on the blue line there, endovascular interventions going up, and the endovascular proponents say as those rates have gone up, amputations have gone down, although it's clear that the reason for that probably is not due to that, but due to better foot care of diabetes in general. But there are some disturbing trends in amputation which are a little concerning. This recent paper in Diabetes Care, I think this is actually Spanish data, but in Western Europe and the United States, a similar trend is seen where although the rates of major limb amputation in type 1 diabetics has dropped considerably over the last decade or so, the same has not been true for amputation in type 2 diabetics. And remember that most of the types of patients that we treat in our practice are going to be type 2 diabetics with peripheral vascular disease. And there, the rate of amputation has been flat and perhaps even increasing a little bit, which is certainly of concern. So I'm going to talk about mortality, mobility, and some quality of life data, and then a little bit about costs, very briefly. So this is from my former institution. We looked at about 1,000 amputations over about a 11-year period and showed that about 3/4 were BKAs, 80% in diabetics, and the mortality rate was 8.6%, much higher for AK than BK, and survival over time, as already been discussed, was diminished. And compared to the PREVENT-3 trial that Dr. Conti just talked about, one can see that the mortality for bypass was 2.7%. So there have been many, many studies over the years where it's shown that the amputation rate has a higher degree of mortality, perioperative mortality, than patients undergoing bypass, although in general long-term survival has not been that much different. Of course, there's a lot of confounding variables, and these groups are not necessarily the same types of patients. And of course, the only way you could really prove conclusively there was a difference would be with a prospective randomized trial, which for ethical reasons could never be done. But using, again, a propensity matched scoring analysis in a retrospective review of the NISQIP database, one can see that even in fairly comparable groups of patients, the mortality rate, this is perioperative, 30-day mortality rate for amputation, exceeds that of bypass in all patients and has exactly the same differences in those patients with critical limb ischemia. So as best as we can tell, there probably is some truth to the concept that an amputation has a higher procedural mortality than bypass in comparable patients. What about mobility? Well, this is Mark Naylor, who's written a lot about outcomes after vascular surgery. Looking at a VA experience, one can see that in this relatively small group with a high percentage of above-the-knee amputations, which I think confounds the conclusions a little bit, only 29% of patients ever became outdoor ambulators, 25% were only indoor ambulators, almost half were non-ambulatory, and only 40% ever used a prosthesis, and 8% lost their independent living status as a result of an amputation. Again, these are dysvascular amputees. Now, perhaps the VA data is not really representative of what's happening, in academic teaching centers or community hospitals. Well, here's a paper from Spence Taylor's group in Greenville looking at maintenance of ambulation after major limb amputation and also independent living. Over time, 2 years, a higher proportion of BK amputees in this group, and also not an insignificant number of bilateral amputees, and one can see that only 50% maintained ambulation over 2 years, and only 70% returned to living at home. So I would submit that these are not very good outcomes for amputation in our typical patients. And the factors associated with not using a prosthesis, you can see here, not surprisingly, the most powerful predictor was being non-ambulatory before surgery. And obviously, a poor functional status before is going to become even worse, if anything, afterwards. But also age, and as you might expect, having an above-the-knee amputation. Interestingly, bilateral amputation was not as powerful a risk factor for not ultimately using a prosthesis. The problem with all of this data is that it's really sort of data looked at from our perspective. These are the factors that we consider important in judging how we should treat our patients. But how about when you look at it from the patient's perspective, and this has already been alluded to a little bit in terms of patients' fears. This is a very interesting paper from a few years ago. It was published in the Journal of Vascular Surgery looking at a new measure that they called the Mobility Success Score. And this was mobility success after a first major limb amputation. This was a prospective cohort study in 87 patients over 12 months. And as you see there, mobility success was defined as a level of mobility was the same or greater than prior to amputation based on the locomotor capability index, the maximum score which is 56. And they also had a quality of life, a life satisfaction questionnaire as a secondary measure that they were looking at. And you can see here they were looking at transmetatarsal, transtibial, transfemoral amputations. The numbers are relatively small, but if you look in terms of what percentage of patients had mobility success after amputation, it was pretty poor. Only 40% of transtibial amputations, for some reason transmet even lower, and for transfemoral amputations, it was only 29%. Now, the p-value was not significant because of the small number of transfemoral amputations, but if you look at the number of patients who were satisfied with their mobility, which was a separate measure that they looked at, only 50% of transtibial patients were satisfied with their mobility, only 29% of transfemoral. And that was important because in their life satisfaction questionnaire, if a patient was satisfied with their mobility, 61% were satisfied with life, but if they were not satisfied with their mobility, which 50% weren't, the majority were not satisfied with the quality of their life. So mobility is a very important factor in our patients' minds in terms of their overall quality of life. Another thing to consider in diabetic patients, something I think we all know, is what's the fate of the contralateral limb after a major amputation. This is again from my former group, looking at a large number of patients over a very long period of time. And one can see the likelihood of a contralateral amputation based on either a primary major or minor amputation on the left panel, and the likelihood of major amputation on the opposite leg in a patient with or without diabetes. And one can see that over a 5-year period, nearly 15% of diabetic patients who had a major amputation on one side went on to have a major amputation on the other. So salvaging limbs, I think, is important given the poor natural history in our patients. What about functional status after bypass? We talked a little bit about functional status after amputation. How about after bypass? This is again from the Vascular Study Group of New England, about 1,560 procedures over a 4-year period, looking at ambulatory status in critical limb ischemia patients undergoing lower extremity bypass. One can see that prior to surgery, 93% were ambulating, and after surgery at 1 year, 88% of survivors achieved ambulatory status. Comparably with residential status, 96% were living home before surgery, and nearly 80% of survivors returned to living home after surgery with some decrement of both ambulation and residential status at discharge for both. So can we really compare the functional outcome of patients having amputation versus bypass? Again, as we talked about with mortality, there's no way really to do this without a prospective randomized trial, which would be unethical. But this is, I think, a reasonably good substitute for this. Again, from the Vascular Study Group of New England, looking at functional status following amputation after lower extremity bypass. So all of these patients had a lower extremity bypass. The majority were done for a critical limb ischemia. And what happened to those patients who had a bypass and an amputation? And they did a functional outcome score, which time doesn't permit to go into in any detail. But one can see in the black life graph at the top, 88% who had no amputation at all maintained a very good functional status after surgery. There was a minor decrease in functional outcome scores in those patients who had minor toe, forefoot amputations. But look at what happened with both BK and AK. And of course, these were the patients whose grafts failed and ultimately lost their limb. Tremendous decrease in their functional outcome. And finally, just briefly about cost. There haven't been many studies. In fact, there hasn't been any recent study in the vascular surgery literature looking at cost of bypass versus amputation. The only study I could find was published many years ago in the 1980s, I think, from New England Medical Center. But this is a REACH registry, which is an AHA-funded registry, looking at the 1 and 2 year cumulative cost of hospitalization for patients with peripheral arterial disease based on their, what was done to them. And one can see the cost of hospitalization at 1 and 2 years for asymptomatic patients with identified PAD, those with claudication, those undergoing revascularizations of any time, and those undergoing amputation. And not unexpectedly, those patients having amputation had the highest 2-year hospitalization costs of this entire group. So in conclusion, I think the data favors revascularization over amputation in the typical patients that we treat in our practice. And I'd point out that although the rate of amputations overall is declining, it's not in our patients with type 2 diabetes, and the answers for that are not entirely clear. But again, as I already alluded to, the perioperative mortality is higher with amputation. It appears to still be higher in comparable patients. Factors reducing functional outcome are common in our patients, and outcome is worse in those patients having amputation compared to bypass. Many do not achieve meaningful ambulation, and the cost for care of patients with amputation is the highest. Thanks very much.